and I'd like to introduce Dr. Ian Turnbull. He's going to talk about our future health, and we have sent out lots of information about our future health. Most of you have already joined up and take part in it. I won't go into detail. Ian, can you unmute?
Sure. No, well, thank you. Thank you, first of all, Brian, for inviting me. And I'm very glad to have been invited because I think um, it's a good opportunity to speak to a grassroots organisation like yourselves. I'm sorry I didn't make much more of the AGM. I've just finished work, so but it was lovely to have been invited and to be given the opportunity to talk about our future health, which is one of the hats I wear, amongst many other amongst many other hats. But what I'll do is I think I'll just crack on with the presentation, and then I'll leave a bit of time for questions if that's okay with you. So let's just see if I can share my screen. There we are. Can you see that just before I
Yes, that's
crank
good.
it up? Brilliant.
Yes.
Right. So, see that too?
Yes.
Brilliant. So, as I said, thank you very much again for inviting me. A small introduction. So I'm Ian Turnbull. I'm a practicing GP. I'm a clinical research fellow in epidemiology at the University of Oxford. And for nearly the last 4 years, so I approached my 4-year anniversary on Monday, I've been a senior clinical advisor at Our Future Health. So I realise some of you may know a little bit about Our Future Health, but I'll sort of take you through it step by step. So in the UK, there are currently about 2.5 million people living with cancer. And by 2030, it's projected that this figure will increase to about 4 million. And in addition, the number of people with diabetes is expected to rise from just under 4 million people a few years ago to just under 5 million by the year 2035. There are more than 100,000 admissions to the UK each year due to heart attacks and cardiovascular disease. And cardiovascular disease is estimated to cost UK taxpayers about £19 billion a year. And when it comes to dementia, for example, the financial cost of healthcare is expected to more than double from £20 billion in 2015 to about £55 billion by 2040. So these are big numbers. And clearly part of the reason for these increased financial costs is that there are more treatments for diseases once people have been diagnosed, often at a late stage of disease. But despite all of these advances in healthcare, the truth is that far from this leading to improved quality of life, increases in healthy life expectancy have actually stalled. And of course, one reason for this is that there's been an emphasis on understanding, diagnosing and treating late-stage disease. I'm sure we can all speculate on other reasons for stalling life expectancy. But what this does accentuate is health inequalities, seen most obviously along sort of ethnic and socio-economic lines. So I'll move the slide on. These figures presented in these graphs show a sort of steady rise in life expectancy in males and females since the early 1980s. And then a sort of plateauing from the late 2000s to the early 2010s. And in the last couple of years, life expectancy has fallen, and most dramatically in men. And this figure, using data from 2018 to 2019 from the English longitudinal study of aging, shows that gradual aggregation increase of multimorbidity with age. That's to say, an increasing number of conditions that people will have as they get older and are living with, but maybe not living very healthy lives, we might say. And this graphic from John Byrne-Murdoch at the Financial Times, who you may be aware of, from the quarterly labour force survey, represents the number of working age adults outside the labour force by long-term health condition or other reason for inactivity before and after the pandemic. And so it shows a trend of increasing mental and physical health problems, contributing more to economic inactivity since the pandemic. So what this all leads to, I suppose, is in healthcare is this kind of course in a disease's natural history. So I hope you can see the figure well enough, but about half of cancer diagnoses begin during an emergency admission. And the majority of activity within the health service takes place during the late stages of disease with acute deterioration, such as exacerbations of COPD or emphysema or acute stroke. And of course, other risk factors contribute to the development of conditions like diabetes and dementia. So that all in all, 10% of healthcare expenditure is made in the last year of life. I'm sure, unless you live under a rock, you'll have noticed the headlines today and read Wes Streeting's assessment of Lord Darcy's new report that recommends, amongst other things, shifting more care from hospitals into communities and taking a more proactive approach towards prevention. So I'll come back to a version of this diagram in a couple of slides' time, and you'll see the difference. So I acknowledge this is a long-term project, but how do we improve things? Well, there's a better prediction of risk with polygenic risk scores, of which I will talk a lot more later. Protein biomarkers, one of which, for example, is PSA, as I heard mentioned in your presentations before. Digital records and also AI, which is the sort of buzzword in research nowadays. And new technology allows us to detect early signs of disease via something called circulating tumor DNA, better imaging techniques, screening for high-risk individuals, and monitoring of precancerous lesions. And then there's earlier therapeutics and medications enabling the control of risk with long-acting injectable medications for example, reducing cholesterol, immunotherapies for control of certain types of cancers. And so this idea of polygenic risk, before we move on from this slide, I'll just talk a little bit about that and define it for you. So polygenic risk score is a statistical calculation that estimates an individual's likelihood of developing a particular medical condition based on the combination of all their genetic information. And basically it's calculated by adding up small effects of many different genes, or what we call variants, across that particular individual's genome. So the genome being their whole genetic sequence. And so this is what you're born with. So it doesn't take into account environmental factors that might contribute to disease. So what you can do is you can combine this polygenic risk score calculation made up of a combination of very small changes, risks associated with individual genes, and then add it together with a score based on environmental factors like, let's say, smoking, alcohol consumption, reduced exercise, and you name it. Different diseases have different sets of risk factors. And you get, when you add these two things together, something called an integrated risk score. And that looks at that person's overall risk according to their genes and to their environment. By the way, if anyone wants to ask any questions in the middle of the talk, if something comes to mind, then please just go ahead. Very happy to be interrupted. So if you remember the slide from before, showing all of that activity happening in the last, 10% of someone's life. We would hope to, optimistically, to see something a little bit more like this, where with improved tools for disease risk prediction, health screening, earlier diagnosis, earlier intervention in what might be disease that hasn't even shown any symptoms yet, we might be in a position to shift everything to the left, rather than leaving everything over on the right side of that spectrum. So this all sort of combines together in the sort of mission statement for Our Future Health. So I've been at Our Future Health for nearly 4 years, as I said, and it started life with a different name, but after about a year of me being there, it was christened as Our Future Health. And it's designed to help people live healthier lives for longer on those sort of 3 pillars of better prevention, early detection, and improved intervention. And it was formed out of the UK's overarching sort of life sciences industrial strategy. It's a collaboration between charities, academic institutions, the NHS, and the whole sort of life sciences industry, which brings to some of the innovations, the healthcare innovations, into this whole equation. So Our Future Health is destined to become the UK's biggest healthcare research platform. We're aiming ambitiously for a cohort of 5 million people across the whole of the UK that's representative of the country's population, as representative as possible, with linkage to lots of different sources of health data, from the NHS, hospital, episode statistics, databases that deal with more sort of socioeconomic data, primary care data. That's the sort of the holy grail of healthcare research, certainly in the UK. And one of the key advantages for this sort of research will be the access to a so-called biobank of DNA from blood samples we take from participants. There are other studies like this in the UK. The one that comes to mind is something called UK Biobank, which is something some of you may have heard of, which has just over 500,000 participants across the United Kingdom. If there's one criticism of UK Biobank, and actually in one of the later slides, I use data from UK Biobank, so it has really pushed on this kind of longitudinal research. The one criticism is that it's not very representative of the UK. It's largely middle-class white people living in urban areas, rather than representative of the sort of rich ethnic mix that we have in this country. And it doesn't cover, as I said, it doesn't cover quite so many rural areas. So the aim is to try and take this program to as many people across the UK as possible. So for fear of sort of repeating myself, the central aim of Our Future Health is to develop a program that curates and links data relevant to people's health on up to 5 million individuals, and to do so with the help of academics, charity, and commercial researchers, because we have to be practical about these things. We need the money from somewhere to do this sort of thing. And the idea is that we would estimate personal disease risk for participants based on their genetic, that's to say their polygenic and integrated risk scores, and non-genetic data from, say, physical measurements we take when you enroll in the program, and from questionnaire responses that participants give. And one of the facets of this is that we will give some information back to participants that's relevant to their health. And then one of the other prongs of the whole program is to have the ability to recontact subgroups of participants based on their personal characteristics or some sort of indicator of their disease so they can take part in other research. For example, if they have a particular genetic variant that might put them at a high risk of a disease like hemochromatosis, for example, which is a disease caused by an excess of iron in the body that, if detected early, can be treated at such a stage that it doesn't go on and cause any ongoing problems. It can be managed before it even becomes a problem. I mean, it's worth saying that all of this work is in its very earliest stages, and it won't be rolled out for a little while yet. And we're very mindful in the program that these things need to be very carefully planned and navigated. And as you can imagine, there's a very solid research ethics at the heart of the program. We don't want to cause any harm to any of the participants, and dealing with this sort of information, there is a risk of doing so. So we have to be as careful with people's data as possible. So some technical slides. Does it say our future health will catalyze? It's difficult for me to see. Will catalyze genetic translational? Okay. So these are some technical slides, so I won't linger too long, but it's important for future discussions about prostate cancer risk. So we've customized what's known as a genotype array with a company called Illumina, which will enable the genotyping of around 700,000 variants. So genotyping is the process by which we sort of determine the genetic makeup of an organism, in this case humans, obviously. And importantly, we can understand better the differences in each individual's genetic makeup. And this array is designed to work well for the UK population, and it includes all these different variants, which are known as single nucleotide polymorphisms, or more easily SNPs, and they contribute to the disease risk and the polygenic and integrated risk scores I mentioned earlier. So 700,000 different variants. So it's a very sort of rich tapestry of these variants. And last year we signed a contract with a company called Genomics PLC to provide those polygenic and integrated risk scores for us. So our future health is part of the UK National Genomics Strategy, which is designed to help us to understand the use of genomics and these polygenic and integrated risk scores in the prevention of common diseases. And we hope that our genetic data will contribute to the evidence base for personalized approaches to prevention and healthcare generally. We'll make these available to the whole research community. As part of our commitment to feedback, we will give participants the opportunity to receive integrated risk scores for certain diseases and to take part in future research. And in the first instance, we're designing studies that will test the clinical, psychological, behavioral aspects of giving back these scores for type 2 diabetes and cardiovascular disease risk, so strokes and heart attacks. And what will be really key to the success of the program and what will make the program sustainable is to be sure that we work closely with people in the NHS. And I say this, you know, as a GP myself, primary care is by far the most important stakeholder we have to consider. And that's to really develop the long-term policies on feedback of this genomic information at this kind of scale, because we are a very large program and will become even larger. So what's involved in bringing these data together for our future health? Well, first of all, this slide shows the different areas of our baseline questionnaire that you answer when you sign up to the program, and it includes assessments of demographic, lifestyle, occupational, family history, different health factor information. So it's sort of a very wide spread of information that is collected in this questionnaire, in this survey. This is a bit of a busy slide, so apologies. What I'm trying to convey is a sort of sequence of events after you sign up for consent. So this consent is done online, and after you're fully recruited. So after you've been recruited, and there's a slide later on that talks a little bit more about the process by which the appointment takes place. Following that assessment, the blood samples are collected and they're linked to different sources of data. Since we're concentrating on all things genetic, we'll generate genetic data from that genotype array that we were talking about earlier, the Illumina genotype array. And we want to really arrive at a place where we have a large group of participants in whom we have a lot of information on their different characteristics, their physical measurements, and their genetics. And as I said earlier, this is part of a wider collaboration between the life sciences sector and the health system. And the slide is sort of crowded with the logos of our different industry and charitable partners who make this a reality, because without their expertise, their funding, we wouldn't be sustainable. And here's a few more, just for good measure. So, how do you take part? So at present, the public receive an invitation letter through the letterboxes with details for sign up if a recruitment site is opening in their area. So I don't know, it's maybe worth a show of hands as to who has signed up for Our Future Health or who has had a local recruitment centre in their area. I haven't got everyone on my screen, but maybe if you can put your hands up by using the different tool, I'll maybe get an idea of how many hands are up. I don't know, let me have a look. Can I see?
Well,
I can see a few hands. I've got 1, 2, possibly more. I can see 2, but doesn't matter. Anyway,
I'd say there's only about 2 there.
There's only 2 there. Oh well, perhaps. And I won't go around asking where everyone is geographically, but the aim of the program is to get around as many places as possible, not only in England, but also in Scotland, Wales, and Northern Ireland. So there are currently, I believe, about 150 different sites in the country. Some of those move around, they're mobile, and some are fixed in locations, usually fairly urban locations, in boot stores across the country. So once you've received your letter and you're aware that there's a recruitment site opening in that particular area, you can make an appointment to have your enrollment completed. You can also sign up off your own bat via the Our Future Health website, and we have people from all over the country signing up, even though they don't have a recruitment site in their area. So once you've done your online registration, you're provided with an information sheet. You can consent online. You complete your baseline questionnaire. And as I said, people attend their appointment in one of these many centres. When you attend the appointment, physical measurements are done, including a blood pressure, heart rate, also a heart rhythm from the blood pressure machine, weight, height, waist circumference, and currently, although this is being reviewed, a point of care test for cholesterol. And these measurements are all given back to the participant in a pro forma. So a sort of a sheet with the handwritten measurements and information containing clinical resources and advice. Here's a few sort of cutouts of from our sort of media splash that occurred when we formally launched recruitment about 2 years ago. 2 years ago in October. So we did get quite a bit of media pickup, but even saying that, I think we're probably better known now than we were 2 years ago, simply because of the scale of the program. So it's true to say that we are recruiting about 2,000 participants each day. And in fact, that number might even be higher. These are possibly out of date. We also have sites in NHS blood and transplant. So if you go and donate blood, now in many of those sites, you can also enroll in the program. So currently, we have these mobile units, we have boot stores, and we have NHS blood and transplant. 3 different ways of joining. So this is a graph showing us exactly the speed with which we've been recruiting people. We've recruited nearly 1 million full participants, so we should breach that fairly quickly over the course of the next month. And we've a bit of a way to go to fulfill the 2.5 million participants who've actually registered. So that's the line at the very top. But eventually, when people fulfill their appointment and they complete their questionnaire, we might get somewhere towards that. But as you can see, we're making fairly steady progress. We've just started recruitment in Scotland in June. Wales recruitment starts next week, and Northern Ireland is probably about a year away for many reasons. They were hit very badly by COVID, and their infrastructure wasn't ready to take on this challenge, but they will be coming to. But they already have recruits in Northern Ireland simply because they've signed up through the website. So we have activity from the Scilly Isles all the way up to Aberdeenshire, Haverfordwest to Enniskillen. So all over the country already. This chart shows a sort of the basic breakdown of our cohort compared with the 2011 census. So we're doing pretty well in making our cohort representative of the British population. But we've still got a little way to go to increase representation of people with African, Caribbean, Pakistani, Bangladeshi ancestry. That's particularly important from a prostate cancer point of view. As you probably know, people of African ancestry have a higher risk of prostate cancer. So we'd be keen to recruit as high a proportion of that ethnic group as possible. And it's really important that we make sure we've got a representative cohort, because it means that the research findings can be applied fairly to all our citizens, not just to white middle-class people. So we have to make sure that we do that. Here's some early data on the distribution of risk factors in our cohort. So specifically for BMI or adiposity and smoking status, and they're pretty similar actually to what we've seen in other large cohort studies. And again, we also have data from our questionnaire on self-reported medical conditions. So we've got these fairly typical prevalences of high blood pressure, previous cardiovascular disease, and diabetes. Again, this shows the distribution of normal, high, and very high cholesterol levels in our cohort. And that looks pretty similar to what we've seen in other studies over the last decade. So we're getting some data slowly. And this is a very similar chart for high blood pressure. Well, that's a pretty typical distribution of high blood pressure in our population by age and by sex. So a few headlines. I'm coming to the end of the presentation. We'll have a diverse and well characterized cohort with genetic and health data linked with all sorts of other data in the UK, and it will be a world-class platform for clinical research. We've already outstripped any other research study in the UK in terms of the number we've recruited, and soon we will be the largest study in the world. And also by the end of this process, we will have the largest multi-ethnic cohort in the UK with over 500,000 non-white British participants. And we'll also have one of the largest cohorts of non-European ancestry. So we'll have a really good resource to a unique opportunity really to understand the differences between the different ethnic groups in terms of the diseases that they get and they're more predisposed to. And we'll actually, and let's not forget young people, we'll also have the largest cohort of young people in the UK, that's people under 40. So probably none of us, unfortunately. But we do have a growing cohort of young people who really aren't represented very well in research at the moment. So to finish, I promised Brian that I would include something relevant to prostate cancer, which only seems right given the audience. So just to be clear, we've committed to providing feedback to participants in the first instance on risk of type 2 diabetes and cardiovascular disease using the risk scores that I talked about. But the genotype array of 700,000 variants does contain the important variants for prostate cancer. So at some point in the future, we will be able to generate polygenic risk scores on other important conditions, including prostate cancer. So watch this space. So this figure comes from a study published 4 years ago from data used from UK Biobank that I've mentioned already. It's a research program that's not dissimilar to our Future Health, and it was on nearly 5,000 prostate cancer cases. So it needs a little bit of explanation, but what it shows, this graph, is that with increasing age along the X, or the bottom axis, the absolute risk of prostate cancer along the vertical axis, the Y-axis, increases, as you would expect. And these risks are all quoted in terms of a 5-year period. So looking at the Y-axis, you can see the 0.05, that means a 5% risk over 5 years of developing prostate cancer. And of course, the general look of the graph, it makes sense. Risks go up over time as age is a risk factor for prostate cancers and many other types of cancer. So in this presentation, the polygenic risk scores were classified as low, average, and high risk. And that was depending on different combinations of these variants. So each individual participant in this study had a different combination of variants, some that contributed to risk of prostate cancer, some that made the risk of prostate cancer lower. And if you throw all of those together, and then you broadly categorize them as low, average, or high risk, that's how you get these different lines on the chart. And the other variable here is family history. So we know that if you've got a first-degree male relative with prostate cancer, it increases your personal risk of prostate cancer. And obviously, talking as a GP, family history is certainly something we would ask about if we were considering screening or investigation for prostate cancer. So each line in this graph is made up of groups of individuals with low, average, and high polygenic risk scores, with or without a positive family history. So if you look at an individual aged 60, for example, with a positive family history and an average risk polygenic risk score, their absolute risk of prostate cancer is actually lower. It's about 3.5%. It's lower than another individual of the same age without a family history, but with a high risk polygenic risk score. In this case of about 4.75%. So what that really shows is it makes a big difference. Polygenic risk scores in this case make a very big difference in terms of refining the risk prediction for prostate cancer. Even more so than family history. So, in fact, the risk factors for prostate cancer is unusual amongst cancers are very few. So, age is one, being male, obviously, having a family history, and being of African ancestry. So you can see that the effect that the polygenic risk score has is quite profound. And we would hope that over time, once we have a maturer cohort and the research is at a stage where we can start sharing these results and start involving more of the public, more of the interested public in this sort of this kind of research, we will start to be able to implement some of this in clinical care. So we'll just have to see how it goes. I haven't included this on the slide, but obviously one of the advantages of having so many people enrolled in this study and having a blood sample is that some of that blood can be used to investigate other biomarkers for prostate. So at the moment we have PSA, and I'm sure, I don't want to teach grandmother to suck eggs, but I'm sure you know a huge amount about PSA and about the potential pitfalls of PSA. And we would hope that with a research program of this magnitude, we would be in a better place to be able to find other better biomarkers that could be used either on their own or in combination with PSA to make the diagnosis of prostate cancer that little bit easier. But all of this is to come. So I think I'll call it a day there, but thanks very much for your attention, and please do feel free to ask questions.
Thank you, Ian. That's been really interesting. Would you like to just stop sharing your screen and then we can pick
Yeah,
up all
sure.
those?
Hang on. Now, how do I do that? Hang on, I'm trying.
Lance, can you?
Hang on.
End slideshow.
Oh, I've ended it, I think. Oh, here we are. Got you. Gotcha. There we go.
Oh, good.
Thank you. I've got some questions, but I'd rather the other members have the opportunity first, because I expect there's quite a few that have got questions. Tim Bonner.
Yes, hello, Ian. Thank you very much indeed for that. Very interesting and very good luck with your program. Can you hear me?
Yes, yeah, absolutely, yeah.
When I was young, our village doctor knew a lot of those things that you're looking at. He knew my grandfather, my grandmother, the family history, what we all did. So in an analog way, that information was all there with a GP. But that isn't there anymore, is it? I don't even know who my GP is, to be honest. We're in a group practice. So that information's sort of been lost. And it seems to me that's what you're bringing back together again.
In a way, and I agree. I mean, it's a great shame that we don't have traditional family doctors who, you know, really are there from cradle to grave. So you do tend to lose that element of understanding of family history.
Yeah.
I think it's true to say that people's recall of family history is sometimes not very good and usually quite non-specific. So if people say they have a family history of cancer, that is unusual in many cases for them to remember which type of cancer. So I think you're right in a way that polygenic risk scores and this sort of innovation in risk prediction could go some way to sort of bridging that gap. But I agree with you. I think it's probably not going to bridge it completely. I don't think with my cynical GP hat on, I don't think we're ever going to be in a situation where we can go back to that kind of style of general practice,
So
which is a shame.
we're not going to get rid of the GP for a blood test and a computer.
Oh, no, not at all. I don't think this will never be automated so that the GP doesn't have a role any longer. I mean, don't get me on my hobby horse, because I could talk all evening about the replacement of GPs with other health professionals who maybe don't have the breadth of knowledge that GPs do have. But that's for another evening. Bring me back for that. Bring me back for that talk.
Thank you.
Question? Okay. See anything you like? What I'd like to ask Ian, you touched on early diagnosis, and obviously we're interested in prostate cancer. Over the last couple of years, we've had about 200 new members join us, and I'm sure that the vast majority of them had no symptoms whatsoever. Many of them will have gone to their GP for a PSA test, and the GP refuses the PSA test because they haven't got any symptoms. So they walk away. Maybe 2 or 3 years later, they go back and say, I'd like a PSA test. We do a paid PSA test, and it's either locally advanced or advanced prostate cancer. So the opportunity was missed at a very early stage to catch the prostate cancer. And we know that it appears to be NICE that have made this rule that the GPs have got to adhere to cause thousands of men to die with prostate cancer each year. And we, as an organisation, as a charity, are always batting our head against brick walls with the GPs, and we can't get past it. What do you suggest we could do?
It's difficult because I think if you were to have a panel of 100 GPs at this meeting tonight, many of them would probably have responded differently to that sort of example you mentioned at the beginning of your question, to a younger person with no symptoms attending, asking for a PSA test. So I think, first of all, there's a variable approach across general practice. Of course, you'll know that the National Screening Committee doesn't endorse the use of PSA as a screening tool, because of fairly good reasons. I think because of concerns over either overdiagnosis or overtreatment, because of the concerns about the validity of the test. All of these things have to be taken into consideration. But I mean, I've certainly been in the position of that GP when I've been asked to do a PSA in an asymptomatic patient, and have been surprised to, receive back an abnormal result that requires treatment. I think the work that we're doing, looking at those genetic risk factors that have until now not really been fully appreciated, as you can see the big step up in risk seen in high risk polygenic risk score individuals. You can see that it is more impressively associated with risk than family history, which in the past was always the first question that a GP would ask when someone comes in with concerns about their risk of prostate cancer. So I envisage a time, hopefully, not too long away, where you would be able to embrace personalized medicine, where you would, have a genetic test that could uncover this high risk of of prostate cancer and have appropriate screening on that basis. So I'd envision, I'd also, it could go the other way where, someone comes in, they have a genetic test and it shows that they're very low risk for prostate cancer. And in fact, we know from previous research that some individuals, if they have, and looking at PSA now, if they have a very low PSA and they're of a certain age, and not even added in the genetic element to this, the likelihood of them going on to develop prostate cancer is near zero. And what we really don't understand is, who are these people? Which buckets do these people fall into? If we knew which buckets they fell into, and we knew how better to tailor our screening and how better to understand which people will go on to develop prostate cancer, we would do it, and we would save the lives that you're talking about, the many hundreds of lives per year that wouldn't be saved under old systems where we haven't got access to these sorts of genetic data. So it's difficult to say. It's difficult to say, but I have hope that over the next few years, the evidence base for this, the understanding of which people fit into which risk categories, that will hopefully influence the screening committees and allow them to make decisions about about who they target and who they don't. I don't know if I've answered your question. It's quite difficult to answer with the current state of the research and
I really appreciate what you said, and this debate could go on for hours and hours and hours. The reason we signed up into our future health is for the future of our children and our grandchildren. We know that it's not going to help us much. So we're going to step back and so it's too late. But I appreciate what you said, so thank you, Ian. Colin Bird.
A question from Colin Bird now.
Yeah.
Hello, Ian. Thank you for a really interesting talk, and I have signed up for Our Future Health. My question involves an assumption that at some time in the future you will be in the position of providing some form of risk assessment to individuals as participants in the program. Is that a valid assumption?
I think the problem we have at the moment is that the science and the evidence base underlying polygenic risk scores and their use in clinical care is not there yet for most diseases. So what you need to do before you start rolling out this, what we call risk stratification, before we start using this sort of technology on real patients in the NHS, we have to understand that it works. So that's the first hurdle to get over.
Yeah.
That in part explains the size of the program. So the program is that big. It's done at that sort of scale in order to try and improve our confidence in the science. And once we've done appropriate sort of research, clinical trials, behavioral research that I mentioned earlier, to try and understand whether it works and how well it works. And if it reaches a certain threshold where the NHS and the National Screening Committee feel that it could be adopted, so you'd have this kind of risk stratified approach to screening where some people on the basis of a test are considered to be high risk and they are the ones who are followed up, they are the ones who are investigated, and people at a lower risk, perhaps are a very, very low, extremely low risk of developing prostate cancer and don't need to go on and have further investigations. And in fact, if they did go on and have investigations, actually the harm from those investigations might outweigh the benefits. If you can put people into those different streams and the National Screening Committee are happy with it, I can imagine that happening certainly in the next 10, 20 years, hopefully sooner. But it really does kind of depend on there being sufficient evidence base for it.
So the follow-up to that is, if and when this does happen, would you envisage providing counselling for those people who are taken aback by what you tell them?
Again, I mean, it's a very good question, and thank you for raising it, because that's why we're taking such care and attention in the early stages of the program to understand the impacts of providing this kind of feedback to, in the first instance, our future health participants. And we realise that if you give this sort of information to people, they may not act in the way that you expect them to. Some people might just put their head in the sand and do a sort of ostrich maneuver, and some people may actually take it up. Some people may be so anxious about the result that it causes them distress and harm. And actually, it's possible that even on the basis of the sort of information, they don't in fact have a diagnosis of prostate cancer, or not likely to develop prostate cancer. There are many other risks we assume there are many other risks for prostate cancer that we're not aware of. So I think we have to be ever so careful how we go about things, providing this feedback to people, because you're right. I mean, it has to be done in the right way, and genetic counsellors are sort of part of our program already. We employ genetic counsellors to ensure that we develop the right kind of materials, the right sort of information, and give the right help to people who might, you know, have that information given back to them. So, yeah, complex and expensive.
Thank you very much. Thank you.
No problem.
Does anybody else have a question they'd like to ask Ian? No, only see any hands.
No, I can't see any physically raised hands, and there's no electronic hands.
Yeah. Okay. Well,
I think it was very well. Yeah.
Thank you, Ian. Thank you very much coming along this evening and giving us your time. I think it's been you've got a hand from Ron.
Yes.
Ron, could you unmute yourself, Ron?
Hi, yeah, I wasn't actually raising my hand. I was doing an electronic clap to thank Ian for a fine presentation.
Oh, thank you. Yeah, I started using Zoom and Teams in earnest back in 2020, as I'm sure we all did, and I still find it difficult sometimes. It's quite an art.
Ian, just to say thank you very much. We did have our tests, our blood test, and as you know, started asking about cholesterol and that sort of thing. And the upshot of it is that Karen sitting next to me had a raised cholesterol, and then when she saw the GP, it was confirmed, and on the basis that she's got a family history, and her mum had a heart attack at the age of 50. She's still alive at 90, by the way.
Well, she's done well if she had a heart attack at 50 and she's still here at 90. Gosh. Yeah. Well, I think what Brian's talking about, just for everyone, is cholesterol. So I did mention this in the talk. Cholesterol is currently measured during the appointment with what we call a point of care test. That's a finger prick test. If you go to your GP and you ask for a cholesterol, it will be taken from a vein in the arm and processed by a laboratory. But these tests are all done using little machines. And we've had a few problems with them. Some of them overestimate cholesterol quite significantly. And for many others, in fact, the cholesterol measurement is most likely going to be there or thereabouts, but because you have your cholesterol done in the appointment using a finger prick test on a different day to when you'd had it done 6 months or 12 months previously with your doctor, there are going to be differences. And I think if you get a value, a cholesterol value, and if that value happens to be different from the one you had at your own doctor's, it causes a bit of concern, and it's something I've been very aware of for the last couple of years. And the whole policy is under review, actually, to use those sorts of tests. But I'm glad in the circumstances that you did get your cholesterols checked, and these sorts of things have been picked up. But it just goes to show, I think, that when you're feeding back this sort of information, and something as simple as a cholesterol test, it has far-reaching consequences. So just imagine the situation when we're feeding back genetic information. It's a whole different level of magnitude, and we have to be ever so careful about how we do it. So, but that's how Brian and I got to know each other, because he contacted me to talk about cholesterol, and here I am presenting to you on a Tuesday evening, Thursday evening, and I'm very, very grateful to have been asked. So thank you.
Thank you very much, Ian. We look forward to hearing a lot more about it in the future.
No problem. All right. Well,
Round
invite me
of
back
applause.
later on.
Thank you.
Thank you, Ian. Thank you.
Thanks ever so much.
Thanks, Ian.
Cheers.
Bye.
I'll leave you all. Cheers. Thanks ever so much. Bye. Bye.
Thank you, Ian. Be in touch. Thank you. So that rounds off the evening.